Good afternoon and welcome back at ECCMID TV, brought live to you from our studio here in Pavilion 1 at the ECCMID Congress Center here in Lisbon, Portugal. My name is Judith Cohen. I'm hosting these ECCMID TV series. And right now we're actually up for our final guest for today, and I am very, very pleased to be able to welcome Dr. Suchi Saria. She's coming to us live in the TV studio, but she's coming from her own workspace in the US. Dr. Suchi Saria is the founder and CEO of Bayesian Health. She holds the John C. Malone Endowed Chair at Johns Hopkins University, where she also is the director of the Machine Learning, Artificial Intelligence and Health Lab. And she will be hosting or holding a keynote lecture tomorrow at 2:45 in Hall A about the AI revolution in medicine. A warm welcome, Dr. Suchi Saria. I'm very happy to have you here with me in the studio. I'm sorry, I have trouble hearing you. I'm just having a little technical problem here, so I'm looking at the crew. This is live television after all.
There's an echo. You can't hear me at all.
There you are. I can hear you right now. Welcome, Suchi.
Thank you so much for having me. Looking forward to the rest of the meeting.
Yeah, well, we're very, very looking forward to hear just a little bit from you. Maybe you can just lift the veil a little bit on what you'll be talking about in your keynote lecture tomorrow. So it's called AI Revolution in Medicine. Well, I think everyone, even though they're not that much affiliated with AI, but knows that it's a true revolution. What are you going to share with the audience tomorrow? Just a little bit.
Yeah. So, I've been in the field of machine learning AI for about 20 years now. And it's been very exciting 20 years in terms of the amount of progress we've made in the field, starting from, advances in other sectors around self-driving cars, voice recognition, automated face detection. But when it comes to medicine, what's been really fun is really a big catalyst has been sort of the implementation of electronic health records, which in the US at least, it's gone from very limited adoption to almost, I would say, 99% adoption at the major health systems in the last decade. And that's meant vast quantities of data are now, real world data are now available, which is exactly the kind of data that, it's hard to leverage the data using standard techniques, but using machine learning, which is, and I'll talk a little bit more about ML and AI, but using ML and AI, we are able to leverage these kinds of messy data to be able to, bring new ways of delivering care, all the way from new screening techniques, new ways to target drugs, new ways to assess who's going to be responding, new ways to do clinical trial recruitment, new ways to then even potentially value payer contracts so we can start really moving towards reimbursing based on patients who are likely to respond rather than the old school ways of doing things where we have very broad indications but limited understanding, which really prevents us from giving approvals to drugs that are likely to succeed on some but maybe not en masse. So I just think it is a sea change in terms of both because of the infrastructure, the data, what's possible, but also because of the maturity of the technology. I started working with large health data sets from electronic health records back in 2008. In the US, that was sort of early days in terms of when these kinds of data, which is starting to be available. It's just been fascinating to see in the last 10 to 12 years how much, how many areas we're already starting to see in imaging FDA-approved techniques for being able to identify, patients who might benefit from surgery, patients who might not benefit from surgery, in cardiology, primarily, for example, or in radiology, being able to triage patients where they may benefit from attention sooner in the emergency department versus not. And then I'll speak a lot, actually, since this is an infectious disease meeting, about the progress we've made in sepsis. We all know in sepsis, one of the most promising avenues for improving outcomes is potentially identifying the patients early and treating them in a timely way. I lost my nephew to sepsis and experienced firsthand sort of like how it's very easy for, in the moment when there's a lot going on, for things to get missed. And, back in 2015, we showed one of the earliest papers that you could use machine learning to identify sepsis early using data that's in the electronic health record and the EHR infrastructure that exists. And since then, there's been a lot of excitement for that kind of work. And to bring it to life in a way that it's implemented and doing prospective studies. So I'll be sharing some early data from like some of the largest studies to date. These are pragmatic studies showing very, very nice, exciting results that I'm very proud of. So yeah, that's what the talk is going to be about, both in terms of what's possible at writ large and then using our own work, our own example, showing work we're doing in the field, but also now partnering with health systems to scale this through Bayesian health.
Yeah, well, these are excellent examples that you're giving us already as just a little tip of the veil. But what is your experience? Like in the early years of machine learning coming up and the AI, there was a little pushback, I guess, from the old school doctors being scared that their roles are going to be taken over by the computers. And I guess the general feel is that, they can now appreciate the way AI is put to use as a tool to help them or aid them in making their clinical decisions. But especially with the example that you just made about your own personal story with your nephew, in which there's AI is being used to make a clinical decision and maybe machine learning can do it better than the doctor. What is your experience with how this is being evaluated in the field? Is there still a lot of pushback, or is it getting better?
Yeah. So I think like any new technology, when new ideas come to the fore, people engage with it starting from, either like their own prior experiences, and it's very natural to imagine and have the kinds of anxieties about, is this, out to get me? Is it something I can trust? Is it something, do I know, can I work with it? How is it going to impact me? And interestingly, in the last 4 to 5 years, I think, again, there we're seeing a lot of maturity, especially in the last 3 years, I'd say. So several things. So first is, the kind of work we're doing at Bayesian and has been all about what I call augmenting the frontline clinicians, as opposed to, so the idea is how can we use this data to make it both easier to practice more effectively. And so when we say easier and then practice more effectively, we mean, well, for example, can we, it's very hard to be by the patient bedside 24/7. It's just hard. So if there's a way by which some other tool can read data from this encounter, past encounters, aggregate it, determine a patient baseline, understand how these different signals interact, to start to rank or grade or prioritize and surface its own inferences in a way that makes it extremely easy for a frontline provider to digest what's going on. Because, the reality is, patients are getting sicker. They have limited time in which they have to do a whole lot more with that time. And it's just extremely hard in their current reality, where they're having to, spend a huge chunk of that time clicking for information, right? They're going from one screen in the electronic health record to a different screen in the electronic health record. And there is no time to look at past encounters, right? You're just sort of in the moment, reacting in the moment. But when there's the ability for a tool or a system to assist with integrating that data, surfacing that data in a meaningful way that makes it extremely easy to parse and identify and not miss critical moments that you might have missed otherwise, in some ways, now it starts to be an assist. It's helping me do what I would have done and wanted to do better. And
Yeah.
it's allowing me at the end of the day, and like the work we're doing in sepsis and other areas, both in the lab, but also through a lot of the work through Bayesian, is very much about um, then, in these moments, we're surfacing, they're able to use that context to be able to make both better decisions, making them sooner, early, and making them faster.
Yeah.
So in some sense, it's a win-win. It's not really trying to replace
No.
or take over decision making. It's mostly assisting in making the decisions more,
Easier.
faster, better.
But the other way around, do we still need human doctors?
Yeah, I mean, at least,
Yeah.
so I think there are areas. So, for instance, in diabetic retinopathy is an area where, patients with diabetes often, end up having this complication, but don't get detected early enough. And the reality is, if you could detect them sooner, you can actually um, improve outcomes. But the issue is, for that, today they have to be referred to a specialist. There
Yeah.
are colleagues of mine doing work with AI where they've been able to build and validate automated screening technology that basically can be implemented at like a drugstore or a grocery store. It's a simple device. They can, just like you're going to go see, uh, a, instead of needing to go to see a specialist, you can take this test very quickly that allows one to assess if you're likely to have diabetic retinopathy. And if so, then, you can get diagnosed earlier and go seek appropriate treatment. So that's an example of a different example where it turns out access is a problem today. Access to specialists, and our current processes aren't set up for patients to be able to access this kind of treatment quickly and early. And instead of it costing, like it costs a third of what the specialist would have charged to see the patient, and it's much more convenient to be able to use an approach like that, in your day easily, and that makes it easier and faster to identify patients at risk. So I think the approach is going to vary a lot depending on the condition. In some areas, it may be better to create automated workflows. In other areas, it may be better to assist and accelerate decision making within current workflows. And I think at the end of the day, the reason all of us get into medicine is because the ultimate thing that really drives us is improving outcomes. And so, in some sense, what I see is a whole new world in which we're going to have the ability to bring together clinicians and combine them with better processing techniques at the fingertips that allows us overall to be able to be more effective together.
Yeah, it seems like the applications are limitless. I mean, there's so much to improve in medicine, in all topics, in all divisions of healthcare. So, I think it's going to be a very interesting session for our viewers also to attend. So it's tomorrow at 2:45 in Hall A. You will be speaking to our attendees online also tomorrow, Suchi, that's correct? Yeah.
That's correct.
And you'll also be hosting the fireplace session tomorrow from 4 to 5, for which a pre-registration was already necessary. Yeah, I think it's a wonderful field, the field of machine learning and artificial intelligence. So I'd highly recommend all of our viewers to take place tomorrow at 2:45. For now, Suchi, I would love to thank you for your attendance here with me live in the TV studio to just give us a little tip of what we can expect tomorrow. So thank you so much for your time already. And for our viewers, this was our final broadcast for today. We will be back with you tomorrow morning at 9. Please tune in at 9 because then Professor Jacob Moran-Gilad, ECCMID's program director, will be back to present to you his personal selection of highlights for the second day of ECCMID. So please Well, we'll be happy to welcome you back tomorrow morning. See you then.